Welcome to Inside View. I'm your host, Joel Metzger. And joining me on the show today is Dr. Randy Smart, and he has a private practice in Murphy's and is an internal medicine specialist. Randy, welcome.
Thank you, Joel. It's good to be here.
Good to have you on the show. I should also mention that you're chairman of medicine at Mark Twain Medical Center. Is that correct?
I am. Thank you.
And many other titles, but if I go into all of those, we probably would spend the entire show just talking about all the things you do.
Let's not.
Okay. So there's a really important topic that we have today, and I think that this is going to be a show that will be really useful to a lot of people. They call it the silent killer. Is that correct?
It is the silent killer. That's exactly right. The topic is high blood pressure, and the medical term for that is hypertension. There are many, many people out in our community and other communities that have that. Mm-hmm. Many of them don't know it, but in a short period of time, we can teach them how to find out and what to do about it.
Is hypertension, is high blood pressure something that has long been an issue, or is it something that is becoming increasingly a worse and worse issue in America?
It's actually been an issue for a long time. But if you go back 100 years in medical history, people didn't really live long enough for hypertension to be that big of an issue. They died of infections and other diseases like tuberculosis. But as we conquered infections and some of the other things, we realized that as people got into their 50s and 60s, they had a new set of problems, one of which is high blood pressure.
Now, it's interesting that it's just a kind of a recent iteration of human events when we actually live past, 40, 50, 60, somewhere in there. And now, what would you say the average age of death is? Are we up into our 70s, 80s now?
The men are in the high 70s and the women are in the low 80s, and those numbers are not static. They're continuing to go up. Mm-hmm. For the medical community, that's really challenging because we're running into diseases and problems we haven't had to really face before, like brain failure, which some will call dementia, but we see more and more of that. Joint failure, where joints just don't work anymore. So it's a new challenge for us, how to build quality and longevity into that group that is getting into the 70s and 80s, and we're doing it. But it is a new thing for us.
So with high blood pressure, first of all, what is high blood pressure?
So you have this beautiful system inside you, a pump, your heart, and all these pipes, which are arteries. And the idea is it pumps oxygen all through your tissues and keeps you alive. The pump is very dynamic. It's a pulsating pump, 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 pulsating. And the arteries are very dynamic. They will expand and contract with every single pump. And so what blood pressure really is when that pulse of blood goes through the artery and the artery is expanded, that is what we call systolic pressure, the higher pressure. Blood pressure is usually described as one number over another, like 120 over 80.
Okay.
So that higher number, the systolic number, is when that artery is at the maximum expansion, the blood is pulsing through. And then after that pulse goes through and the artery relaxes and becomes small again, that's the bottom number, and that's called the diastolic pressure. And every heartbeat, 120, 80, 122, 70, 120, 86. And so that's how our systems are designed. And people started measuring that a long, long time ago. If you go into some of the old French hospitals from the 1700s, they were measuring blood pressure and looking at blood pressure. And where it becomes important in health is we know that blood pressure contributes to organ diseases and organ problems. And if you look at our culture, if you look at the American culture, the number one thing we die from is cardiovascular disease. The thing you and I are most likely to die from is a heart attack or a stroke. And then it becomes cancer and other, but the cardiovascular thing is still at the forefront. And so when we look at cardiovascular disease, we know that there are things that accelerate it or contribute to it. Things like age, things like cholesterol, tobacco, diabetes, but clearly one of those things is blood pressure and high blood pressure. And what we know is some of those things we can't change. For example, we can't change your age, probably can't change your family history, but we can change your blood pressure and we can change your cholesterol. And so the things that we can change, we started changing really back in the early 1960s when we started really treating high blood pressure, 50s, 60s. And we know from really good epidemiologic data that as we lower blood pressure, we lower strokes and we lower heart attacks. And that's why so many of us are living to be 70s and 80s and beyond. But the challenge is that blood pressure is really an asymptomatic, or as you say, silent problem. And so many people out there don't know if they have high blood pressure or not, or they have a misconception that as long as I don't have headaches, I don't have high blood pressure, or, as long as I feel okay, I'm fine. And that's clearly a misperception. And so what we do is we screen people for high blood pressure by measuring their blood pressure. And we don't always do it the right way. For example, we do it in environments that sometimes have a lot of tension and anxiety, like a dental office. Not the best place to measure blood pressure. Right. But we screen for it and we try to identify those that have it. But if you haven't gone to a dentist or gone to a doctor or been to a hospital and you're one of the many, many people out there, you don't know it. You would have no idea because it just doesn't cause symptoms until you're pretty late in the game.
So you could have no symptoms and then experience a heart attack? That could be a scenario?
Absolutely.
That seems almost unfair.
And in many, it is unfair, and that's why I'm here.
Yeah.
And in many of those cases, that heart attack can be fatal within minutes. So you could never have a symptom in your life and hit the ground for the last time. That's preventable. So when we measure blood pressure, there are blood pressure cuffs, is what we call them. I picked one up today in town. And what we know is blood pressure really needs to be measured around the arm, the upper arm. There are devices that use the wrist, the finger. I had one patient whose wristwatch took his blood pressure. We don't think those are accurate or reliable. It's not the way we understand the problem. And so we really encourage blood pressure measurements to be around the arm. Surprisingly enough, your arms don't have the same blood pressure. One arm is higher than the other, usually.
Why would that be?
We don't really know because it's not always the left arm. It can be the right arm, so it's not the arm closest to the heart or closest to the pump. Maybe it has to do with the arterial tension. But one arm generally is higher than the other. And what we want to do is we want to measure the highest arm. So when we talk to people about blood pressure, we say, look, we want you to measure it in the morning because we know the morning measurements are the most accurate, and there's lots of variation during the day. We want them to be at rest, and at rest for 10 to 15 minutes. 15 is better. We don't want them to have just finished a big meal or a cigarette. And then we want them to use the high arm. And whatever arm is highest will always be the highest. So if we measure both your arms right now and your left arm is the highest, then your left arm is the one you always measure.
And that way you have a consistency there. you're always looking at the same arm. You're not going back and forth and having different readings.
Correct, and you're using the arm that the medical research community is using. They use the highest arm.
Always good to do that.
Right, exactly, yeah. If you want to duplicate the results.
How does the actual measurement work? How does the technology actually figure out what the measurement is?
So what happens, and we can show the audience if you'd like, the cuff will get tighter and tighter until it cuts off the circulation. A little bit uncomfortable, but tolerable. And then it will detect when the circulation first starts through there. And then there are certain sounds that it'll listen to and analyze. There are actually 5 different sounds, and it's that 5th sound where it'll determine what the bottom number is.
Okay.
Now, a normal blood pressure is 120/80. Lots of variation. Younger people have lower blood pressures. They'll have blood pressures of 90/50. Children have much lower blood pressures. I think women have lower blood pressures in general. And low blood pressure is not a problem. It's not a disease. In fact, people with low blood pressure live much longer. It's a good thing to have. There is lots of variation. What we know is that as people age, their blood pressure goes higher for the majority of those.
What would cause that?
Well, we think there are lots of reasons, but I think the predominant reason has to do with the elasticity of those arteries. So as we age, there's all this elastic, very distensible tissue in you, including your heart arteries. And as we age, that elasticity diminishes. They become harder. Now, part of that is deposits of cholesterol called atherosclerosis. Part of it is just hardening of the arteries. And if you can think about a pipe, that no longer can distend and control the pressure in the pipe. Now it's a rigid pipe, and the heart's still pumping and pumping strong. The pressure goes up.
Okay.
And so as people age, their blood pressure goes up for almost all of us. That's when we want to intervene. That's when we want to find out when people are hypertensive, and we want to give them the tools both to figure that out and to do something about it.
But even before you get to a point where you may have hypertension, would there be a lifestyle that you could endeavor to live that would perhaps push that date farther back, or maybe?
Absolutely.
And what would some of those things be?
So not only does that lifestyle prevent hypertension, but once somebody becomes hypertensive, it can lower their blood pressure. So it's both preventative and therapeutic. We know the things that help are weight loss. And as you know, weight is a big issue in our culture, and even a little bit of weight loss can have a big effect on blood pressure. Even just 5 to 7 pounds can make a big difference in blood pressure. So weight loss has a very big impact. The quality of the diet has a big impact, and we can go back to that if you'd like. We think exercise has a big impact on that. And we recommend that people have active lifestyles and that they have sort of an aerobic exercise plan that they try to adhere to. Tobacco contributes, so less tobacco helps, or stopping is ideal. Alcohol in excess can contribute, so we encourage less of that. There are people who are what we call salt sensitive. So for some people, salt makes a big difference with whether their blood pressure is up or down. And we kind of teach them to figure that out by putting them on a low salt diet, measuring their blood pressure. And if they're salt sensitive, then backing off on the salt is a great idea.
What about stress? Does that have any impact on blood pressure?
Absolutely. Yeah,
It does.
absolutely. But we don't understand whether less stress really has an impact on morbidity and mortality. And it kind of, that segues into what is a normal blood pressure, and why do you measure it in the morning? So if you look at blood pressure through the day, it is up and down all day long for all of us, for you, for me, for everybody. And then when we sleep at night, it drops down significantly, like 20, 30 points.
Wow.
And when you're asleep, the whole thing is just calm and low. And then when you get up in the morning, it's back up. But we know that with exercise, your blood pressure goes up. Like if your blood pressure was 120 right now, which it probably is, and you and I were to take a jog and really do some endurance, your blood pressure would probably go up to 160. And we know that, and that's normal. We don't think that's a disease. We're still trying to decide, what if it goes up to 200 or 220? Mm-hmm. And there is some evidence that those people are more at risk for hypertension later in life. But that your blood pressure, as far as we know, is supposed to go up when you exercise. Or if you were to injure yourself, with a hammer or some tool, we know your blood pressure will go up. So if you're in an emergency room or an acute care clinic with a black eye and you have high blood pressure, that doesn't mean you have high blood pressure. That means you have a black eye and you're having pain or something.
So kind of the fight or flight response is going to spike blood pressure?
Exactly. And that's adrenaline. Okay. And if we put adrenaline into you right now, we know your pulse and your blood pressure would go up. And that probably has some survival benefits for us. But the blood pressure at rest is the one we know is the one that puts people at risk, and that's the one we look for. Now, most people, some of the disabled may not be able to do this, but most people can buy a blood pressure cuff. I bought one today.
Let's see it.
In town. And this costs $29, so it's not a big expense. And it has a cuff and a meter that reads out. And so this is a very easy thing to use. It goes around your arm.
Shall we do it real quick, Randy?
We could do it.
Do I need to have no sleeve or?
You can do it over your sleeve as long as it's a thin sleeve like yours.
Okay.
And let's see, we're going to put your arm through there.
Okay.
And you're going to put the artery is on the inside of the arm, and it shows you that. And then you're just going to tighten that up snug.
Okay.
It's that easy.
It's that easy.
It's that easy. This has batteries in it, so you don't have to have a stethoscope or anything fancy. Nobody should really be using that. I hit the on button.
Okay.
And it'll take your blood pressure.
So anyone could grab this for $30 and they could have this and do this each day if they wanted to? How often would you recommend?
Well, preferable if you're concerned about your blood pressure and you want to know if it's high or not, you should do it every morning.
Every morning?
Maybe for a month.
Okay.
And if we can talk about what the goal is, but if the numbers are good, then you could maybe do it once a week or once a month, and if they start to go up, then you do it more often and you decide. But preferably at least at first every morning.
Okay.
Now your blood pressure is great. It's 133/87.
Now you said 120/80 was normal.
I did, didn't I?
Yes, you did.
So what is abnormal? Abnormal is a little bit age dependent, but for those that are over 60, we want it to be under 150/90.
Okay.
Now there are exceptions to that. If people have diabetes or they have heart problems or they've had strokes before, then the numbers are different. But for the average person, we want it to be under 150/90. If they are under 60, between 30 and 60, then the number is closer to 140 over 90.
As something you'd be concerned about?
As the point where we say if it's always over 140 over 90, you probably have hypertension.
Okay.
Now that doesn't mean every single time you measure it. That means the majority of the time, because there'll be some days where there is more stress, or you didn't rest long enough, or maybe you were up all night and your blood pressure will be higher, and that doesn't necessarily mean you have high blood pressure.
So if someone determines, and again, they're not experiencing symptoms, most likely, so this is I'm going to see a doctor, or I'm going to get one of these, and I'm going to actually be proactive about this, and they determine, okay, this is kind of a little bit concerning. Let's say they did it at home. Is the first thing to do to go see someone like you?
Yeah, well, what you would do is you would write it down, and in these little kits, they give you a little chart you can write on, and you just write it down. And if you're concerned, then you don't have to see a specialist. You don't have to see a cardiologist, or I'm an internist. You don't have to see me, although we do a lot of this. But you can see really any primary care provider, any of the clinics, your own primary care provider. You can see any primary care provider, and they will probably do a little bit of testing. They'll want to test, do some blood tests. They may want to do an EKG, just to make sure they have a full understanding of everything that about you. Mm-hmm. And then many times we will say, why don't you go out for a couple months and change your lifestyle? Why don't you start eating better? Why don't you exercise more? Why don't you lose some weight? Maybe less cigarettes? And then keep doing this and come back and let's look at the numbers. And honestly, Joel, in a significant number of people, those things alone, those actions alone, will bring these numbers down to where they need to be.
Wow.
Exactly. This is all about empowerment. I mean, people can measure their own blood pressure. They can manage their own blood pressure. Now, there are those who are unable to do that, or even though they do that, they still haven't reached their goal. And for those patients, we prescribe medications. I counted them a couple of years ago. I don't know why. But there are something like 65, 67 different blood pressure medicines.
That seems like a lot.
There are a lot.
Okay.
There are a lot. And so when we treat blood pressure with prescriptions or medications, there are categories of medications. There's diuretics, which are a fluid management pill. There are beta blockers, which relax the arteries in the heart more. There's calcium channel blockers. There's multiple different classes of medications. And typically what we do is we try to pick something that we know the patient can take. And what we know is that people can take once a day medicine, but as you get to twice a day or 3 times a day, they don't do it. We know they don't. We've proved that again and again. Now, sometimes you have to do that, but for the most part, we pick a medicine that is a once-a-day medicine. We try to, in my practice, pick something that is covered by their insurance and inexpensive, so it's not a cost issue, because if it becomes a cost issue, they don't do it.
Sure.
And oftentimes, blood pressure medicines can be used for 2 problems. For example, I saw a patient last week who had migraine headaches, and her migraine headaches were incapacitating. And you can use a blood pressure medicine to treat both the blood pressure and the migraine headache, same medicine. And it's not like you take twice the dose, but the same medicine will treat both. And it's not that the migraine is caused by the blood pressure. As far as we know, that doesn't happen. It's just that the medicine happens to work for both. Okay. So a lot of times we'll try to customize a prescription where we can treat more than one problem. For example, the patient may have asthma, and sometimes we can modify their blood pressure medicines to help with that. But that's kind of what we try to do. Now, when we put them on medications, sometimes they have the perception that the very next day their blood pressure will be normal.
Not the case.
Does not happen.
Can we take yours as well?
Yes, absolutely.
Okay, so slip it on and I'll keep you asking you questions once it's on there.
I think my right arm tends to be the highest.
The high one, okay.
So when we start the blood pressure medicines, often, would you like to push the button?
I'll push the button. Okay.
Often we'll wait at least a month before we make a determination about whether it's effective or not effective, meeting goals or not meeting goals.
And again, this is preferably after you've tried a lifestyle change to start. And if that wasn't effective or they couldn't make that change, would you then do a medication?
Always.
Got it.
Lifestyle changes first because
Okay.
they work. But we'll try a medicine for a month. Sometimes we'll have to change to another medicine. Oh my gosh. Bad info.
Maybe do it again?
Maybe.
Okay.
So sometimes we'll have to change to another medicine. Sometimes we'll use 2 medicines in low doses. But it ends up being a little bit of thoughtful trial and error till where you get to where you need to be. We also know that treating blood pressure earlier is way easier than treating it later. If it stays high for very long, it becomes what we call resistant high blood pressure. I'm not sure I'm going to want to look at this. And if it is, oh, that's way better.
Way better than the first one, yeah.
So what they do in the trials is they will take your blood pressure 3 times 5 minutes apart.
And will they average it then, or
No, they take the lowest.
the lowest? Okay.
Yeah, they take the lowest. So they'll take one 5 minutes later, they'll take another, and 5 later, another.
So we only have a minute left, but if we're going to leave people with anything, this is a good thing to keep an eye on, and even if you're young, it doesn't have to be that you're 60, 70 years old to be looking at this, right?
Yeah, honestly, we start to screen for high blood pressure at about 40.
40, okay.
But I mean, we never look at blood pressure really before 18. And so if a 20 or a 30-year-old wants to look at blood pressure, that's absolutely fine. There's no problem with that. Okay. But we know the prevalence starts to hit at about 40 to 50 years old, and that's when we really start looking.
Okay, so pay attention to it. Make the lifestyle changes first, and then if that doesn't work, there are medications that can also help. But it's key to get that down because of all of the implications that can come from having high blood pressure for an extended period of time.
Absolutely.
And I want to tell our folks that we want to have you back for more topics like this because these are great, and I think it would really help the community to be aware of things they can do.
I would be happy to. There's many topics.
Okay, thanks, Randy.
Thank you.
And thank you for joining me on this edition of Inside View. I'm your host, Joel Metzger, and I hope you join me next time.